Dr. Garima here, and to everybody out here who's watching this video, this is another Australian Dental Council exam question. Though I've solved previously RPD related questions and have given out brief explanations about the RPD, still a few of the candidates keep feeling that their knowledge about RPD is way less. And like I mentioned before, I understand that because you as a third year, fourth year BDS and intern student do not do cast partial dentures. All we do is acrylic partial dentures, RPD. We just take impressions, send to lab, the lab makes it and we deliver. We actually do not make a design of a cast partial denture which is made in cobalt chromium. We do not design the rest seats. We do not design the denture base or the major connector, the design of the minor connector, nothing. We don't do anything now because we have not done it. We have just read it. It's really difficult to imagine how it would be in a normal patient. And worldwide, cast partial dentures are preferred over the acrylic ones because of their stability, their strength, and the fact that you can feel temperature with it. So you people are going to be very happy with this video. It's one of that TMJ-like videos, where I've tried my best to give you a very brief, concise explanation of the entire removable partial denture. Basically, like I've searched and searched until I found good videos which were just related to this topic and had nothing extra, and they were easier for you to understand. And I thought instead of me making an elaborate presentation, I might as well take help and give credit to all those people who have already done that, and instead show their presentations to you all because they have done a fabulous job. So why not spread more word about them? I always appreciate good work and like to credit them whenever I can. So this is today's question about cast partial denture. Okay, I'm not reading the question at the moment. We will solve it together once we have brushed up our theory. Now this is going to be a really long video because you cannot just concise the entire Stewart book which is on cast partial denture. It's like what, 400, 500 pages book, a very thick book, in a matter of like 10 minutes, right? So it's not that long a video also, but it will take like 40 minutes or so, I guess. So you can keep on pausing in between and you can make your notes, and of course you can revisit this video whenever you would like. So we are talking about removable partial dentures, specifically the cast partial denture. So we will first start by understanding the Kennedy's classification, okay? So here is Kennedy's classification, and let us understand that.
Course proposed by Dr. Edward Kennedy himself classifies the partially edentulous state into 4 different classes based on the position of the absent teeth, which could then be treated with a removable partial denture. This classification basically allows us to formulate a treatment plan, making it easier to communicate between professionals and also easier for visualization of an edentulous arc. So let's look into the Kennedy's 4 classes. So first, the class 1, which states that bilaterally edentulous area located posterior to the remaining natural teeth. So this over here is a representation of a dentition of a single jaw, and I will be using this image as a reference in my further discussions. So the teeth were absent on both sides, that is the right and the left side. Like over here, the first, second and third molars of both sides are absent, and also this edentulous area is behind the remaining natural teeth. Therefore, this edentulous state will be classified as class 1. So the next class, the class 2, states that unilateral edentulous area located posterior to the remaining natural teeth. So now the teeth are absent only on the one side, either on the left or on the right, and are still behind the remaining natural teeth. So this state will be classified as class 2. So the next, class 3, states that a unilateral edentulous area with natural teeth both anterior and posterior to it. So for an edentulous area to be classified into class 3, it needs to have a unilateral edentulous area between the natural teeth. Like in this case, the second premolar and the first molar is missing, and this edentulous area is located between the remaining natural teeth. Therefore, it is classified as class 3. And finally, the class 4 states that a single but bilateral edentulous area located anterior to the remaining natural teeth. So like over here is a bilateral edentulous area because it is crossing the midline, but it is still a single area because there are no teeth present in between. So it is still a single but bilateral edentulous area crossing the midline. So therefore it is classified into class 4. So these were the 4 classes of Kennedy's classification of edentulous states. So next we have the Applegate's rule, which are in total 8 rules proposed by Applegate for helping us to classify multiple edentulous areas and also for the better understanding and better application of Kennedy's classification in our everyday life. So let's go through these 8 rules. So the rule number 1 states that classification should follow rather than precede any extraction of the teeth that might alter the original classification. So this rule basically means that the classification of the edentulous state should be done after any extraction has been performed, not before the extraction, since the extraction of the teeth may alter the classification. Like this arc is right now a class 3, but if I were to extract the second and the third molars, now this arc is no longer class 3, rather it has now become class 2. So this rule basically means that classification should always be done after the performing the extractions. So the next rule states, if the third molar is missing and is not to be replaced, it will not be considered in the classification. So like in this example, both the third molars are missing as well as the first molar on one side is missing. So we will not classify it as class 1. We will classify it as class 3 according to the missing first molar. The same goes if the third molar is only missing on one side. If we have no intentions of replacing this third molar on the other side, we will simply not consider it while classifying the edentulous state. So this will still be class 3 state. So the next rule states that if the third molar is present and it is to be used as an abutment, it is considered in the classification. So an abutment is basically the tooth from which the denture takes its support from. So we'll take the same example as the previous case. So if in this case we are going to use the present third molar as an abutment for our denture, then we will include it in the classification. So now since we are going to use this third molar as a support for our denture, therefore this will now be classified as class 2 modification 1. So I will explain about the modifications in the rule number 6. So don't worry about that. So the next rule, rule number 4 states that if the second molar is missing and not to be replaced, it is not considered in the classification. So like in this case, we are missing the second molar and the third molars on the both sides. Along with that, we are also missing 2 premolars but only on the one side. So if we have no intentions of replacing these absent second molars, we will not include them in the classification and we will simply classify it as class 3. And the same goes if the second molar is absent only on the one side as it was with the third molar. Moving on, rule number 5 states that the most posterior edentulous area always determines the classification. So like in this example, there are 2 different edentulous areas. So according to the rule, we will classify according to the most posterior edentulous area. So in this example, we will classify it as class 3 modification 1. So the next rule basically explains the modification system. It states that the edentulous area other than those that determine the classification are referred to as modifications and are designated by their numbers. So this example over here will be classified as class 3 modification 2 because there are 2 additional edentulous area other than this one that is determining the classification. So the one that is determining the classification will not be included in the modification, while the rest of the edentulous area will be known as modifications. So the second last rule, rule 7, states that extent of modification is not considered, only the number of additional areas is considered. Like in this example over here, there are many edentulous areas. So according to Kennedy's classification, it will be classified as class 3. Now since both sides have the same number of missing teeth, so you can take any one side for the classification. So for me, I'm going to take this side. So this is now class 3, modification 1, 2 and 3. So this example over here is class 3, modification 3. So as you can see, there are multiple missing teeth in each of the areas, but still they are considered as a single modification. So basically the number of teeth absent are irrelevant, only the number of edentulous areas is what matters. And in this case, there are 3 additional edentulous areas, therefore it is known as class 3 modification 3. So now the final rule states that no modification area can be included in class 4. So over here, according to Kennedy's classification, is a class 4 because the edentulous area is crossing the midline and is located anterior to the remaining natural teeth. But if in this example, if I remove a second molar, so now it will not be class 4 modification 1. Because rule number 5 states that the most posterior edentulous area always determines the classification. So this has now become class 3 modification 1. Similarly, if I remove these two remaining first and second molars, so this has now become class 2 modification 1. And finally, if I remove the molars on the opposite side as well, so it will then become class 1 modification 1. So basically what I mean to say is that all the classes can have modifications except for class 4, which can never have a modification. So that's
So I hope this was clear. Now you can re-watch this section again and again until you understand this completely. Very concise, very clear explanation. So you should not be having any confusion with that. Okay, so now that we finished Kennedy's classification, we are going to understand what are parts of a removable partial denture, the cast partial denture, alright?
here we will be looking into the parts of a removable partial denture. So the removable partial denture has in total 8 different parts named as the major connectors, the minor connectors, the rests, the direct retainers, the stabilizing components, the indirect retainers, the denture base, and the artificial teeth. So each of these parts has a specific function to perform, and we will be briefly going through them. So the first part is the major connector. Now a removable partial denture should ideally extend to both sides of the arc to give it a more stable design, and the component that connects the two main parts of the denture is known as the major connector. So a major connector basically performs the role of connecting both sides of the prosthesis, and while doing that it essentially transfers the functional forces that are being applied on the artificial teeth as well as on the denture base, thereby distributing the forces of mastication equally along the entire arc. And all of this essentially provides an optimum stability to the prosthesis. Now there are many different types of major connectors that I will be discussing in my some other video, but the basic principle remains the same. Now the next part is the minor connector. So the minor connector are also like major connectors, connecting different parts of the prosthesis, but their role is essentially to connect the smaller parts like the clasp assembly, the indirect retainers or the occlusal rests to the major connector. And by providing these connections, it also essentially helps in distribution of the applied functional forces, and thereby stabilizing the prosthesis and transferring the stress evenly across the different parts of the prosthesis. So that's the reason why there are so many minor connectors present on a single denture. So the third part is the rests. So the rest is basically a part of the prosthesis that is placed on a tooth surface and provides the vertical support to the denture. And by providing this vertical support, it maintains the components of the prosthesis in their plane positions. Other than this, the rest also maintain established occlusal relationship, and they also direct and distribute the occlusal loads to the abutment teeth. The rest also make up the indirect retainer, which will be discussed further. So moving on, we have the direct retainers. So direct retainer by definition is that part of the prosthesis that engages an abutment tooth, or in some cases it may also engage an implant. So it essentially helps the prosthesis to resist its displacement away from the tooth or the tissues. So the direct retainers can either be a part of the clasp assembly along with other components of the clasp assembly, or it can either be in the form of an attachment. So the next part is the stabilizing component or the reciprocal component. So as the name indicates, these are essentially present to stabilize the prosthesis and help the retainer arm. And for doing that, the reciprocating component essentially provides reciprocation and counteracts the lateral forces of the retentive arm that the retentive arm applies to the abutment tooth. So the next are the indirect retainers. Now indirect retainer is not a specific component, it is rather a group of different components. So the importance of indirect retainer lies when making a denture with distal extensions. Like the denture of Kennedy's class 1 and class 2 have distal extensions. because they both have posterior edentulous area. So in these cases where the denture has a distal extension, there exists a very high chance of dislodgement simply because it is supported only on one side by the abutment teeth. And these distal extensions tend to dislodge and rotate the denture around the fulcrum line. So the fulcrum line is essentially the line or the axis around which the denture tends to rotate when the denture is being subjected to forces that direct it away from the ridge. So in cases like these, the use of indirect retainers becomes very important as to avoid the dislodgement of denture. So an indirect retainer basically consists of one or more occlusal rest and supporting minor connectors. Also, when placing an indirect retainer, one thing we need to keep in mind is that the indirect retainer should always be placed opposite to the fulcrum line, as far away from the distal extension base as possible. So theoretically, the best place for the indirect retainer would be in the close vicinity of the incisor tooth, but they may not be as strong enough to support the components of the indirect retainer. Therefore, in such situations, the nearest canine tooth or the mesial surface of the first molar may be used despite them being closer to the fulcrum line. So if possible, 2 indirect retainers should be used to compensate for the compromised distance. So the next component is the denture base. So the denture base essentially supports the artificial teeth and holds them in their place. It also receives the occlusal forces and transfers these forces to the supporting oral structures. Other than this, it also has an aesthetic function by providing a more natural looking look to the wearer. It also works as a stimulator to the underlying tissues, providing stimulation to the oral tissues, which thereby maintain their form and tone. And finally, in the end, we have the artificial teeth that are resting on the denture basis. So apart from looking aesthetically pleasing while talking and smiling, these teeth also play a role in transferring the occlusal forces to the denture basis.
So these were the parts of the cast partial denture. I hope now it's very clear in your mind what is the major connector, what's a minor connector, what's a direct retainer, what's an indirect retainer. I'll be shooting another video on just direct retainers for the fixed partial dentures, which has those precision attachments and the semi-precision attachments. I do not want to complicate this video by introducing that video. I want you all to be in the zone of the RPD itself. Now, having understood this, introducing another video which is just about the class will also elongate this video. So let's keep that for some other video. But this much explanation should be enough for you to understand the concepts and answer the next scenario-based question that we are going to take. But just before I proceed to that, 2 other pictures I would like you all to see. So this is what a cast partial denture looks like when there is a class 3 Kennedy's classification. Class 3 we just studied now is an edentulous space where the abutment teeth are present anteriorly and posteriorly. Now, what is happening here is a design has been made and we have a major connector, we have a minor connector. Now, this is a clasped assembly here, here and here. I want you all to see this area. This is called as an embrasure clasp. Embrasure clasp, the name itself says that the clasp is in the embrasure. Embrasure is the area between 2 teeth. Embrasure is an area between 2 teeth. That means 2 teeth next to each other should be present. Embrasure clasp cannot be given if a tooth is here and there is nothing next to it. You understand? 2 teeth together have to be joined, and in between this area the embrasure clasp is going to come. So remember this concept. Second picture I want you all to see is this. This is a crawl eye-bar clasp. Here the tooth is there and there is no tooth next to it. Now this is an occlusal rest seat. Now but this is a clasp. Now this is the infra-bulge area of the tooth. We'll talk about the supra-bulge and the infra-bulge when we are dealing with the direct retainers. And this basically goes near the gingival area and engages in the supra-bulge portion of the tooth because the clasp itself is on the infra-bulge area. So because the tooth structure is like this, anything which is here will not lift up because this supra-bulge area is going to prevent it, thereby giving it retention. And whenever forces are applied on the denture, it's just gonna go down a little bit, thereby breaking the stress of the occlusal forces. We'll discuss more about that, but at the moment I want you to understand this is what an I-bar looks like and this is what an embrasure clasp looks like. Yeah, you see, this is a very good presentation of the embrasure clasp. Now, having understood this, let's solve the next question. A 48-year-old female presents at your clinic requesting you to replace her lower partial denture, an acrylic one. So she already has an acrylic denture and she's asking you to replace it. And that was made 10 years ago, but now has become loose and unstable. Okay. So since 10 years the same denture it's used, that means when the denture was made, it was fitting nicely, and the fact that she continued to use it for the next so many years means that the denture was nice, but now it's become loose. Why? Because first of all, relining, rebasing perhaps has not been done, and the bone resorption has happened. Okay, so when the bone is going to resorb, the measurements of the denture changes, of course, and then it becomes loose. She has an intact upper dentition. Her medical history reveals post-operative bleeding problems and hypertension. All right. Now, I want to go to the question part. I do not want you all to see the answers because I want you all to think about it. Now, what is considered to be a major factor in residual ridge resorption? RRR, residual ridge resorption. Major factor. Occlusal forces, bone density, medical history for osteoporosis, and ill-fitting prosthesis. Bone density, medical history, I'm going to rule it out because people are healthy and still residual ridge resorption happens, so that is not like of importance or priority. If I were to be confused, I would be confused between occlusal forces or ill-fitting prosthesis. Now see, if ill-fitting prosthesis was the issue, patient will not wear it. You understand? If the patient is not wearing it, then it cannot be a factor for residual ridge resorption. It can be, but not to that extent. You wouldn't wear something which is discomforting in your mouth, right? So what is the major problem in resorption of the bone? Occlusal forces. Because the tissues take a lot of load when teeth are missing, and when you keep a denture base over it, and the occlusal forces are coming up, the biting pressure basically, it's just going to hit the bone on and on. Teeth were supposed to take that pressure, but the teeth are not there, so the bone is taking the pressure and the bone resorbs faster, right? So residual ridge resorption is predominantly caused majorly by the occlusal forces. What Kennedy classification is this case? Now, what did we see here? What was the question? Bilaterally edentulous distal to the lower premolars. So lower premolars are there, and bilaterally edentulous, no molars on both the sides, class 1. Right? We just studied. You cannot be confused in this. Straightforward question. It's like a chocolate being handed out to you because it's such a straightforward question. Just straight away marked Kennedy's classification 1. Now you decided to provide a rigid direct retainer assembly. Rigid. You are not giving acrylic, right? Earlier there was acrylic. You're planning to change, and you're planning a rigid direct retainer assembly. Which material would you select? We have understood so far what is a direct retainer. Direct retainer is the one on which the rest seats can come, right? And I've decided to give a rigid one. So what is my material of choice? Porcelain you cannot give because it cannot bend, and you don't want to give porcelain. It's not that strong. It will just crash. Gold, decent, but it's very malleable, and a thin portion of the gold can bend very easily, plus it will be so expensive. Acrylic, we are not deciding to go with acrylic, right? We are giving a rigid direct retainer assembly. So cast partial dentures, cobalt, chromium, cast partial dentures, the name itself, cobalt, chromium. Cobalt is the answer of choice here. You prefer to incorporate the RPI, that is rest, proximal plate, and I-bar. You remember this design which I showed you? No, not this one. Rest, proximal plate, and I-bar. This is the RPI system. Why did I select this? Why am I choosing this option? Will it increase my retention, or will it decrease the stress on my abutment tooth? More comfort to the patient, or it facilitates laboratory procedure? Lab procedure, I'm not concerned because anyways you're just going to melt the cobalt chromium, and whichever design is there, it's going to form, so it's not going to facilitate, and that is not my concern. My concern should be more towards the patient, and I want to preserve the longevity of the remaining teeth. So more comfort is okay, but still my priority should be what? It is to preserve the condition of the remaining abutment tooth, especially on which I'm going to add on extra support so that my denture base can stay, right? Increases retention and decreases stress on abutment teeth. Increase retention, the best one would be a complete circlet clasp, like I'm entirely hugging the abutment tooth, that is the best kind of retention. But what will happen? Why do you think these people end up with like bilateral edentulous spaces? Like, what happened? It's not like one day the patient woke up and came to you saying, I lost all my molars. Why this happened? It happened because earlier one molar was lost, and a denture was given with that hugging clasp, which is the full 360-degree encircling the clasp, or the traditional clasps, which are two C-shaped clasps attaching to the abutment tooth. Now what these clasps do, they kind of, so imagine I'm hugging a tooth like this, and a constant pressure is being put on me, and I'm just rotating the it's like a ball dancing going on with the abutment tooth. So slowly I'm just rotating, and after some time the tooth kind of becomes loose, because this is exactly how an extraction is done, right? But in very slow motion. And then suddenly the patient will say, doctor, the tooth next to the tooth which fell off is also wobbly. You end up removing that tooth, and then you repeat with the another denture. In the same motion you hug the tooth which is more anteriorly, and thereby one tooth by one tooth by one tooth, it goes on to be lost. You understand? That is how people end up with bilateral edentulous areas. It's not like suddenly only the posterior areas became periodontally weak, or in majority of the cases I'm talking about. So yeah, so what I need to do, so that again I do not lose the premolar tooth just as how the molars were lost, I would like to decrease the stress on the abutment tooth. How I'm gonna decrease the stress on the abutment tooth? By giving this one. So the only way you can decrease is by giving that eye bar. So that is my main concern. Yes, so yeah, I had paused this video, I had a call, so I'm back now. So I discussed about the RPSE, right? Now, which of the following is considered the least favorable choice of retainer in a distal extension removable partial denture design? Akers, eye-bar, embrasure, rot. Okay, rot wire is a very thin wire. Sometimes you have to give this. Why? Because the abutment tooth is either tilted, or the contour of the tooth is such that normal clasp assembly will not fit, or the clasp has broken, and on an emergency basis you want to give a clasp, so a rot wire clasp can be given. So it's not like that it's least preferred, but it can be given. Eye-bar is a preferred one. Distal extension. Akers clasp, let's see what's an Akers clasp. No, but if I'm going to type here, my video will stop because S will come, and I've put the end key buttons here. But anyways, you can Google up what is Akers clasp. It is a normal C-shaped clasp kind of a thing, but it is not so damaging as much as that encircling full clasp, right? Now the embrasure clasp, I showed you what an embrasure clasp is. You cannot give that in a distal extension case. Let's go back to embrasure clasp, because so imagine this tooth was missing. How can you give an embrasure clasp here? There is no other tooth out here. You get it? Embrasure clasp, like I had mentioned, requires two teeth next to each other. So that is the least preferred form of clasp. You just cannot give that clasp, correct? So that should be our answer. So but let me see if I can type Akers clasp here and find something. Akers, yeah. Oh wow, great. Images. Circumferential or Akers clasp. Yeah. So this is how a circlet or an Akers clasp looks like. It goes. It's a reciprocal action. It's not like hugging the tooth at the same direction as what I was explaining to cause rotation. but on one side it has a reciprocal arm and it has a normal arm. So it kind of just holds the tooth like this, like at an angle, like this. It is not like this, it is like this. So one arm is infra bulge and one arm is kind of a supra bulge. So this is how it's gonna look like. One arm is infra bulge and one is a supra bulge. So if you're holding the tooth like this, then you cannot move it like this because it's just engaged. But if you're holding the tooth like this, then it gets moved. You understand that? So yeah. So embrasure clasp is least preferred is basically the answer of choice out here. So there, we solved the question. It's almost like I don't know how many minutes and a long video. Pause this, repeat, rewatch, learn more. More concepts to be discussed on direct retainers, precision attachments, semi-precision attachments, etc. We'll do that in next video. Bye-bye.